Good morning. While we're waiting, I'd just like to thank the program committee for allowing me the opportunity to speak this morning. I'm going to talk about chronic venous dysfunction and the post-thrombotic syndrome. So just as a background, deep vein thrombosis we know is common, roughly 500,000 cases of venous thromboembolism annually in the United States. And the incidence seems to be increasing because I think our patients are more complex, our population is getting older, our procedures are more complex, and that all leads to an increasing incidence. Post-thrombotic syndrome can develop in up to 50% of these patients that are suffering DVT, including severe post-thrombotic syndrome in up to 10% of patients. And I think prevention and prophylaxis is really our key. So how do we describe post-thrombotic syndrome? Well, there's no absolute diagnostic criteria, but we define it as these long-term sequelae that we see in patients who've had deep vein thrombosis, including clinical signs and symptoms related to ambulatory venous hypertension. We use the SEEP and Villalta scores to help us identify the severity of those clinical signs and symptoms. But again, those are not diagnostic criteria. The social impact to our patients is pretty significant. These patients have a quality of life similar to patients with heart failure or with malignancies. The annual cost can be $5,000 to $7,000 per annum, and up to 2 million missed workdays is our estimates. So as we said, about 50% of patients may develop symptoms. Men seem to be more commonly affected than women. The risk is increased in patients who have proximal DVT compared to distal. However, patients with distal or caffeine DVT can develop post-thrombotic syndrome. The symptoms may present shortly after the deep vein thrombosis, and they may have early signs and symptoms even at 30 days, or we may not see these symptoms until many years later. And many DVT are silent, clinically silent, so we may find evidence of chronic thrombotic disease in patients that have no identified history but now have post-thrombotic syndrome. When we look at the etiology of ambulatory venous hypertension, there's really three components. One is obstruction. This may be partial or complete venous obstruction. Reflux due to valvular injury, and that may be axial, superficial, or perforator reflux. And then calf muscle pump dysfunction. Many of these patients have comorbidities that lead to decreased activity, prolonged dependency, or even an impaired gait. And you can see on the right-hand side of your slide that patients who have obstruction and reflux are more likely to have clinical signs as well as clinical symptoms compared to patients who have reflux or obstruction alone. What are those signs and symptoms? The things we see with venous insufficiency: heaviness, aching, swelling of the legs. We can see edema and trophic skin changes. The condition can wax and wane, so they may have good days and bad days, and they'll frequently have exacerbations, which leads to additional imaging because patients are at risk for recurrent venous thromboembolism. So many of these patients will have ultrasounds on a periodic basis due to these waxing and waning symptoms. Ultrasound is a wonderful tool to help us anatomically and physiologically look at the veins. Unfortunately, again, it does not identify or diagnose post-thrombotic syndrome. That's a clinical diagnosis. Anatomically, we can see things like intraluminal webs or stranding within the vein. We can see evidence of wall thickening or fibrosis, recanalization, or even occlusive changes. Physiologically, we're looking for venous flow. Is it present? Is it absent? Is it normal? Or do we have evidence for obstructive flow or valvular reflux? Reflux occurs when we have loss of that normal valve integrity, so now we have retrograde flow in the venous system. And then we may see changes of monophasic flow, where we have a continuous flow along the baseline of our duplex with a blunted response to augmentation. That suggests a more proximal occlusive process and may be consistent, again, with post-thrombotic syndrome, but definitely not diagnostic. The pathophysiology is complex. There's really two components. There's the outflow obstructive component, and then there's the inflammatory response component. But the combination of these lead to endothelial injury, valve injury. They create, during the healing process, a very stiff, non-compliant vein wall, and then that leads to associated venous hypertension. The venous hypertension is reflected at the level of the capillary bed, and that's what leads to the edema, the tissue fibrosis, and ultimately hypoxia and potential for ulceration. It really sets up this chronic inflammatory state. From a medical standpoint, how do we manage this? We have to ask our patients to maintain an ideal body weight. Central obesity is certainly a contributor to venous hypertension. Limb elevation, skin care, and compression. Compression is the mainstay, and they offer a lot of benefits to these patients. They augment the calf muscle pump, improve calf ejection volume as well as ejection fraction, and they help us control the edema. Decreasing the edema can also help improve the inflammation, and they'll lead to decreased inflammation and assist with venous leg ulcer healing. This is just one study, a very small number of patients, but it looked at patients with C2 through C5 disease, so mild to moderate or severe disease, and looked at resting pressure and standing pressure. And you can see, compared to the normal patient, which is the left-hand side of each bar, when we use no compression versus elastic compression versus an inelastic compression, our inelastic compression can near normalize both ejection volume as well as ejection fraction. So it really is a mainstay of our therapy in these patients. Now, there's a lot of debate on the value of compression. More of the debate, I think, frankly, is on prevention. Once a patient has post-thrombotic syndrome, I don't think we debate too much about the value of managing the post-thrombotic syndrome with the compression stockings. But there is a fair amount of debate on how we can prevent post-thrombotic syndrome. And at least from the AHA guidelines, a trial of elastic compression stockings may be considered in patients who don't have contraindications. And that's based on the fact that there's probably a low risk of harm, there's potential benefits from the stockings for prevention, and it should be one of our considerations. There's one trial that looked at stockings and the value of treating patients with PTS, looking at thigh-high versus knee-high stockings. This is, again, a small trial, 34 patients, but they actually used air plethysmography and then demonstrated significant improvements in the venous filling index, venous volume, and venous filling time. And those benefits were the same whether that was a knee-high or a thigh-high stocking. So when you're considering placing your patients in a stocking, this is really patient preference. Do they prefer a knee-high? Do they prefer a thigh-high? I find compliance is better with knee-high stockings. So in conclusion, post-thrombotic syndrome is really related to that inflammatory and obstructive process and that injury that occurs at the time of deep vein thrombosis. The chronic symptoms are related to obstruction as well as reflux, and then that remodeling of the vein wall that occurs. Compression impacts venous function. It is a mainstay of medical management, but ultimately, prevention is key, and I think we're still embarking on our tools to help with that preventive therapy. With that, I thank you for your attention.